to join. Yeah, thank you very much for the opportunity to join in and also share the little that I have learned over the years. So, um, I'm Daniel Nang-Tege Ekuman. I prefer to be called Nang-Tege um, for easy identification. It also helps me not to, I always say, to run away from crime because then if they mention Nang-Tege, it's very, very easy to, to, to find me um, around. Um, I am currently a postgraduate a research student with the University of Derby, but a little bit about my background. So I started with a diploma in nursing um, in 2010 after going to the Presbyterian Nursing Training College in Boko. Um, I have worked most of my life in two predominantly deprived areas when it comes to health structure. I was in Abuja for most of my period that is in Ghana. I proceeded to do a BSc in emergency nursing. That is where my interest in emergency response and disaster management all started. Um, However, I noticed along the line there were a lot of health and safety uh, issues regarding the health delivery system in Africa, Ghana not exempted, and particularly within the area that I worked, which is emergency care, emergency response, and disaster management. So um, I took the advantage to get some knowledge and skill in occupational health, safety, and environmental management with the Ghana Institute of Professional Administration, GIMPA, and then took it further to the UK where I did my MSc in Security Intelligence Disaster Management. Um, Currently, I am looking at point of care ultrasound in emergency response and disaster management for my postgraduate research project or my doctoral research project. So that is a bit about myself. Along the line, I have been a faculty for the American Heart Association uh, for basic life support and advanced life support, equally working with other professional colleagues on ATLS trainings and also mass casualty mulage trainings. So that is a bit about myself. I don't know why this keeps appearing, but I will deal with it every time it comes around. Sorry about that. So today we're going to discuss basic life support, and just for participants to be aware, this presentation is not the entire training that you need to become a certified BLS provider. The aim of this presentation is to basically give you some knowledge and also reveal to you some of the rationale underpinning the criticality of BLS. Focus is going to be on adult CPR or BLS, cardiopulmonary resuscitation. Uh, Most of the materials that are used for this presentation are coming from the resource pack that I had or have as an American Heart Association BLS and ACLS provider and instructor. Um, Other trainings, I must say, such as the UK Resuscitation Council, which I have encountered in the last few years, is of similar standard. They are just negligible changes or differences that exist between the two. And I will always recommend, no matter what training that you undergo, including this presentation, always try to stick to your local protocols also because they are very, very much equally important and they take into consideration the structures that are within the areas that you work. Okay. Now, the outline of our presentation, we're going to have a quick pretest. It's just for survey purposes, feedback basically, an overview. We look at why CPR, cardiopulmonary resuscitation, is critical. We delve into the chain of survival for BLS. We try to put all together to see how this chain of survival will run every time that we are needing to use it. And then a few take-home points, a post-test survey, reference and acknowledgement, and time for questions and answers. So if you have your phones on you, I'll be very happy for you to probably just scan the QR code, and I think it's going to take you just about a minute or so. Just take the pre-test survey for me is just to see how some of these trainings actually are helping us develop our knowledge and skill. I hope we all can access the QR code. Hello.
Yes, we can say access the QR code.
Okay. Um, if others want the link, I can post the link also into the chat. I've seen a message. Let me just check that out. Okay, good. So I'm just going to um, try to get a link and send it to you guys. I might have to get out of my slideshow to get it. Okay, oh, don't worry, I've got it. Okay, so I'm just putting the link here. So that's a link to the pretest. I'm just giving a minute for us to have a go at it. Those who are using the QR code, also you can go ahead with that. Okay. So let's have a quick overview whilst we have people answering the pretest. So about every 90 seconds, a person dies from sudden cardiac arrest. And I must say these are figures mostly related to the Western world, specifically the USA. Approximately more than 17 million deaths yearly are caused by heart disease. And there is on record that 350,000 adults in the United States alone experienced non-traumatic out-of-hospital cardiac arrest. That was in 2015. In 2020, however, estimated sudden cardiac arrest mortality in the US alone was about 436,852. Now, less than 40% of adults receiving layperson initiated cardiopulmonary resuscitation, and then we have fewer than 12% who have had the privilege of getting an automated external defibrillator, what we call the AED, applied to them before professional help arrives. Now, if these are figures in the USA, I wonder what is happening in our continent and various subregions within the continent where we basically do not have some of these structures in place. Approximately 1.2 of adults admitted to the US hospital suffer in-hospital cardiac arrest. So this is just to let us know that cardiac arrest, that is a condition that leads to the need to do cardiopulmonary resuscitation or to initiate a sequence of BLS, does not happen only out of hospital, but can also happen right under our watch in our clinical areas. Nearly 3 out of 4 cardiac arrests happen in out of hospital settings, and then we know that yes, there are some of them that will definitely go on to happen in our clinical area. Now, the reason why CPR, cardiopulmonary resuscitation, which is the main component of basic life support, critical, is that if initiated immediately after a cardiac arrest has been confirmed, it can double or triple the person's chances of survival. And the rationale basically is that you are attempting to keep blood flow that has partially stopped because the heart has stopped working effectively to the person. And you can do this just by performing CPR until medical staff arrive to help. In 2021, data from US out of hospital settings revealed that 9.1 of all emergency related non-traumatic out of hospital cardiac arrest patients were successfully discharged to go back to their homes or to continue living their lives. Now we're going to look at the chain of survival, that is the protocol for which we follow to be able to perform BLS or go through CPR successfully. Now I'm going to quickly speak with the out of hospital chain of survival, but knowing that this platform is predominantly health professionals, and I know there might be one or two people that might have joined probably on basis of wanting to learn something with BLS. Um, so the out of hospital chain of survival and the in hospital chain of survival are very similar. Now, one caution I must probably put out there is that every component of this chain of survival is equally critical. So I will encourage a participant that in the event of you following this chain of survival, you do not downplay one or the other, because the chain is as strong as its weakest side. So if you downplay one, it will have that domino effect on the other aspects of the chain of survival. So in an out of hospital setting, once that you identify that a person has a cardiac arrest and will go through that, you want to activate the emergency response system. And if you have some knowledge, we encourage you to start high quality CPR, which we will look at also subsequently. Then, if you are privileged to be in a settings where AEDs are very common, you would want to immediately defibrillate this person. Sorry. And then we will have the advanced resuscitation, which is mostly being delivered by the emergency medical technicians who are usually manning our ambulances. When they arrive, they will take over from you, get this particular patient or victim to the appropriate health facility where post cardiac arrest care will be initiated. And then this will lead on to recovery and reintegration back into their community. Now, in the in-hospital system, we realize that there is a search for, or there's a search button which basically depicts early recognition and prevention of cardiac arrest. This is to tell us that cardiac arrest in clinical areas can actually be predicted most of the time, and then we can have a good chance of preventing them happening. Now, in the event where we are unable to prevent a cardiac arrest from happening for a patient, we will ask that you activate the emergency response system, follow the chain by starting or initiating high quality cardiopulmonary resuscitation. If you have an AED on your unit or in the area where you found this unresponsive Hello. So just to confirm, was this a slide I went off?
Kindly go a little back.
Okay.
Exactly.
Okay. So what I was saying with the chain of survival is that each component of the chain of survival is very much as important as the other. So if it is the in-hospital, you want to make sure that you are surveilling very well to be able to get your signs, your early signs to prevent the cardiac arrest. If it is that you pick up one, that is good. If you are not able and there's a cardiac arrest, you want to immediately activate the emergency response system. Continue with high quality CPR. Get your defibrillator or your AED, depending on which one is available to you, and then you want to move the patient into the post cardiac arrest care setting. Most of the time is going to be the ICU or the cath lab, but we're going to have a look at that a little bit. So in the clinical setting, and I'm moving a little bit into the clinical setting because I suppose most of us might be from the clinical background, is that I want you to have a greater attention, or to pay greater attention to patients that have these conditions. Now, these are called the reversible causes of cardiac arrest. So any patient that is in your care that is hypovolemic, is continuously hypoxic, the blood gases are revealing that they are acidotic, there is hypokalemia, or they are continuously hypothermic, you want to keep an eye on them because they can immediately arrest. It's just a matter of time if they find themselves in these states. Also, you are looking at patients that have been exposed to toxins like drugs, both recreational drugs, and sometimes patients in our care who, because of their conditions, have been given so many medications. You want to have a look at them because sometimes some of these medications might react and push the patients towards a certain direction. Cardiac tamponade, mostly related to trauma patients. Tension pneumothorax, also mostly related to trauma patients. You want to look at thrombosis, either coronary or pulmonary. Now, hypoglycemia some time back used to be part of the H's and T's, but hypoglycemia has currently been taken out of the H's and T's based on research findings. However, I will encourage that depending on your clinical settings and the patients you are dealing with, to consider hypoglycemia as one that will probably take your patient into a deteriorative state and then probably cause them to arrest, mostly with our diabetic patients. Now, how do you activate the emergency response system within your clinical settings? Growing up, I know for sure in Ghana, and I'd like to hear from one or two of you. Immediately somebody falls down, the first thing that we used to do, and still very much do in most settings, is start shouting, "Jesus, Jesus." I don't know whether Jesus was to get the AED for us, or he was supposed to come down and start the cardiopulmonary resuscitation sequence for us, but I don't know in other countries. You can just pop it into the chat space, how commonly people activate emergency response system in your country, or if you just want to speak up also, I think it's fine for us to do that. Anyone want to share from a very specific geographical location how you activate the emergency response there? Hello? Yeah, go ahead. Go ahead. Hello? I saw someone's hand up.
Okay, so this is Nat.
Yeah, Nat.
Yeah, I'm a nurse also in Ghana, working in St. Francis in central part of Ghana.
Okay.
So We activate ours by shouting code.
Okay, just
And
code.
that will just activate the system. Yes.
Okay, just code. Any other experience from somewhere else?
Hello, I am a free, also a nurse in Ghana, Kumasi. And I know others to shout code blue.
Code blue. Okay,
Yes,
code
please.
blue.
Thank you.
Okay. So it's one thing that I want to emphasize with this particular slide is that local protocols are very, very much important, just as the skills and knowledge that you acquire. Because within your settings, you might have to call 121, as I know in Ghana. In the UK, you might have to call 111, 999, depending on where you find yourself. In most hospitals, or some hospitals will tell you, you dial 2222. So knowing your clinical settings or the environment that you work in and how to activate the emergency response system is very, very critical, just as the knowledge that you have in performing CPR or BLS. Now, high quality CPR, cardiopulmonary resuscitation, some years back used to take the form of ABC. Current research has proven that the sequence of CAB, which we say CAB, is more effective in giving us the results that we want in trying to resuscitate people. So the C standing for compressions, which we encourage to push hard and push fast. We're going to have a look at that. The A is trying to open up the airway, and once you have a very clear airway, you want to help this person to breathe. Now, chest compression characteristics. So the C component of the CAB, that when you are performing CPR, is that you need to place your hand correctly. So it's not just putting your hand anywhere on the chest wall, or as we taught previously, is that you look for where the heart is and you put your hand there. And we all know that the heart is towards the left side of the chest wall. So before I got into nursing, even with the little I knew, all what I knew is that you put your hand where the heart is. And I know some people still think that once your hands are closer to the region of the heart, then you are going to be performing effective CPR. No, your hand has to be placed the lower half of the breastbone. Medically, we call that the mediastinum. But if you're a lay person and you want to locate this particular place, if you're non-clinical, you want to locate this particular place. Mostly in males, we say you draw an imaginary straight line between the two nipples. And then where they meet in the center of the chest, that is where you want to place the heel of your arm, one arm, and then you want to interlace, depending on the technique you are using, whether you are using one-hand technique or you are using a two-hand technique, as you can see in the pictures over there. Now, your targeted rate is 100 to 120 chest compressions per minute. Some years back, we used to target 100. But then we realized that if you're having ineffective chest compressions, what then happens is that you are not helping the patient. So a target of 100 to a 120 on an average, if even you are having 10 ineffective chest compressions or 20 ineffective chest compressions, then you are coming down between 110 to 90, which is relatively very, very good heart rate for every adult that we have. Now, the depth, how deep should you? I remember my first chest compression that I was doing under training at the Konfanochi Teaching Hospital. I was scared to push. I was afraid I would break the ribs of the patient because I felt that, oh, I had some little bit of extra muscles on my body. But research has found out that mostly we fail to push deep enough. And so we are saying that you should push 1/3 of the AP diameter of the chest. Usually, I don't like using the 5 to 6 centimeters because I don't know how you are going to measure that if you are doing active CPR. But the good news for CPR nowadays is that we have feedback devices that we can place on these patients that could tell us whether the depth that we are compressing the chest is adequate or not adequate, and also the rate. Now, you push hard, you push fast, but it is critical to allow for chest recoil. Now, the reason why you need to allow the chest to fully recoil is basically because when you compress the heart, you want it to expand again for blood to rush in. You don't want to continuously be compressing an empty heart. So it is critical to push deep enough to maintain your rate of 100 to 120. But equally, if you are not allowing chest recoil, then you are not helping your patient that you are trying to resuscitate. Now let's move to the A part of the CAB, which is opening the airway. Now predominantly we use two techniques, which is the head tilt and chin lift, which is the first picture that you see. But we encourage that you don't use head tilt and chin lift for suspected C-spine injury patients, and these are mostly patients that have been involved in trauma or polytrauma patients. When you are not sure, we encourage you to use a second picture or technique, which is a jaw thrust, because that one saves you from further damaging the person's C-spine if it has already been injured. Okay, now let's look. After you have opened your airway, you want to breathe for this person using one of these techniques, either the mouth to mouth, the pocket mask, or the bag valve mask, which we commonly call the ambu bag. And I know that we are all clinicians, but maybe there might be one or two people who are not. So I usually work with my mask all the time. It's always packed in my bag wherever I'm going, and this was kind of a routine I picked after my training with the American Heart Association, because I realized that a cardiac arrest can occur anywhere, and I'm not comfortable giving mouth to mouth, so I'll better work with my pocket mask. I'm not sure they are that costly, and I'll encourage that if you are really passionate about saving lives, you probably would want to get one after you've gotten properly trained, and just keep it on you. You don't know when it will come in handy for you to save a life. Now, whether you ventilating your patient by mouth, by pocket mask, or using the bag valve mask, one thing you should know is that it doesn't change the breaths that you are delivering. You still are delivering breaths. The technique doesn't change. Although the technique changes, but the breaths that you are delivering is still with the same rationale. Now, characteristically, you want to give the breath over 1 second. So one thing that I realized going around in Ghana and training is that yes, you are delivering breaths, but it's either we are pushing it in too fast or we are too slow. Now, for each breath that you push into the patient, regardless of the technique, is supposed to be over 1 second. Now, we usually say enough. And when we are using the ambu bag, as we commonly call it, half of the ambu bag, we don't have to press everything. You don't have to empty the air or the oxygen in the ambu bag into the patient, just enough. And when we say enough, that is half. Some literature say that is about 500 mils of air you are pushing in. Now, the best evidence, if you are not within the hospital settings or if you are limited in resources, is that you are going to have the chest rise as your only evidence. So once there is adequate chest rise, once you see the patient's chest rising, then you are doing enough. Be very careful not to hyperventilate, which you would see that at a point in time your patient's abdomen will be distended. Now, if you hyperventilate, what basically happens is that it increases intrathoracic pressure, and that will reduce the amount of space that your heart is able to take up when it's expanding, and it's going to go against the amount of blood that you can push around the patient's body once you are doing your chest compressions. So the next in the chain of survival is to defibrillate very, very early. Now, for basic life support purposes, we usually don't talk about the defibrillator, but we talk about the automated external defibrillator, which is the AED, but not the manual one. This is because almost everyone can use an AED. It comes with voice prompts. You just need to listen to it. It will mostly direct to you. You don't need a specific brand of AED to save a life, and that is why I deliberately chose this picture to show a diversity of brands. If you have a specific brand that you've been working with and you think you're comfortable with that, that is okay, but you don't necessarily need a specific brand AED to work with. And please, if you are fortunate to have AEDs within your settings, get familiar with it. It will surprise you that where you turn the AED on one particular brand will be different from where you are turning it off, and the way you plug in the parts might be different. So please try to make sure that you familiarize yourself with some of these equipments within your clinical area. Now, the next chain in the chain of survival is effective advanced cardiovascular life support. Now, this is not for the purpose of today's presentation, but once the emergency medical technicians arrive or advanced professionals arrive, what they will basically start doing is to step up the game by placing in airway agents using manual defibrillators, which mostly can detect other rhythms. They can print out an ECG, read, interpret it, and know what is actually happening, secure an IV line, manage the C-spine if they are suspecting there are issues with it, and even stop bleeding. Sometimes there are medications that are initiated, but this is outside the scope of basic life support or CPR. But just to mention, as long as it is part of the chain of survival. If you find yourself within the clinical setting, sometimes it will overlap your BLS, because if the system is well structured, sometimes you don't even finish 2 cycles of chest compressions, and then the advanced life support team is in, and then they will take over, or probably you join them to take care of the patient. So post-cardiac arrest care basically looks at the specific underlying condition that push the patient into cardiac arrest. Now, again, it is dependent on the environment that you find yourself. It could start in the ambulance, depending on the equipment that they have, and it could also start or finish up in the cath lab or in the ICU. Now, mostly it is a transition period between BLS and ACLS. The main essence of post-cardiac arrest care is to pick up the conditions that we failed to pick up that led to the cardiac arrest, and to prevent our patient from rearresting, because sometimes it's enough to bring the patient back, but if you don't deal with the acidosis, if you don't deal with the hyperkalemia, if you don't deal with the hypothermia, they will just go back and rearrest, and you are not sure that if your patient arrests for a second time or a third time, you are going to get them back. And if even you get them back, whether you're going to get them back in very good condition is another question to ponder. Now, depending on the capacity of your clinical setting, post-cardiac arrest care will usually also begin definitive care, that is putting in a chest tube and all those stuff. I'm seeing some questions, but I will tackle them once I'm done with the presentation, if that is okay, or some contributions we can highlight once I'm done with the presentation. Okay, so recovery is basically trying to reintegrate this person back into the society. That is after we've treated the underlying problem and we feel that, okay, we can move them back to either a cold area, or probably they can be discharged into the community for continuity of care. Now, we are going to try to put all together, assuming that we've had somebody who probably has collapsed on the floor, and maybe after this training or after getting more training, you want to help save this person. You first have to verify scene safety. It is very important that you identify that your scene is safe, not just for the patient, but also for yourself. In the era of the COVID pandemic, scene safety included making sure that you had your PPE on, and so sometimes someone will arrest and you see the healthcare professionals will have to get their PPE on before. It wasn't wrong. It is part of scene safety. And if you think that you are dealing with a highly infectious patient who has arrested, scene safety includes making sure that you have your PPE on before you approach the scene to try to resuscitate this patient. You want to check for responsiveness by tapping their shoulders or by shaking them rigorously, and mentioning their name if you know them, or just hello, are you okay? Now, you want to immediately activate the emergency response system depending on your local protocol if there is no response. And then you want to get your AED, or you want to send somebody to get the AED for you. Now, once you have done these first steps, the next thing you want to do is that you want to confirm whether there is an actual cardiac arrest, or you want to try to identify that there's a possible cardiac arrest. Now, you want to check your patient's pulse if it's an adult from the carotid artery. So that is where you're going to check for the pulse, the presence or absence of pulse in adults. So you're checking for the presence or absence of pulse, but you are also looking at the chest to make sure that you are visualizing whether there is any breathing, signs of breathing. Some resources still mention that you should put your cheeks by the nose and mouth, but we know that in the era of infections like the COVID pandemic, you wouldn't want to go that close to the patient. Also, we've realized that if you can confirm by looking at the chest that there is no chest rise and fall, and there is no pulse, within 10 seconds, we encourage that you initiate your sequence. Now, if your patient has a pulse or is breathing, if your patient, you want to monitor them until advanced care arrives. If your patient has a pulse but is not breathing very well, you want to go to this side where you are going to provide what we call rescue breaths. So you give one breath, either mouth to mouth with your mask, packet mask, or with your ambu bag. You give one breath over every 6 seconds for an adult. You are targeting about 10 breaths per minute. Now, every 2 minutes, we encourage you to go back to this part and check your pulse and your breathing. If you are able to bring the patient back to a bit of normalcy, that is fine. But if after 2 minutes there is no pulse and breathing at this point in time, you want to start high quality CPR by initiating your chest compressions. Now, the ratio for chest compressions for adults is 30:2. Whether you are one rescuer or two rescuers, is 30:2. Reason being that cardiac arrest in adults is mostly cardiac related, and whereas cardiac arrest in kids or pediatrics is mostly respiratory related or related to shock. So basically, the reason being, that is the rationale behind you wanting to stay with 30:2 for every adult, whether you are one rescuer, two rescuers, or multiple, and more than two rescuers. Now, because the heart stopped working due to an arrhythmia, immediately you have your AED in place. You want to attach it to the patient, because the AED will identify whether whatever rhythm led to the cardiac arrest is a shockable rhythm or a non-shockable rhythm. Now, if your AED detects that it's a shockable rhythm, it will direct you to stay clear your patient, it will count down, and it will deliver a shock. Once that shock is delivered, you want to resume chest compressions until you are relieved by advanced life support team. Now, if your AED detects that there is no shockable rhythm, what you want to do is that you want to resume immediately doing your chest compressions and your breathing delivery by 30:2. Now, ventricular fibrillation is the most common cause of cardiac arrest when mostly you're talking about adults. So basically, the AED will pick this up really quick and will then initiate that shock that it is supposed to deliver. A quick mention about PIDs. I'm just going to touch about the differences because it's predominantly the same sequence. But in PIDs, one thing that you want to do is that if you are going to check for your pulse, you are checking for the pulse at the brachial artery. You're checking for pediatric pulse at the brachial artery. Now, there are out of the context or out of the book situations. So I remember in one classical case that I was part of trying to resuscitate a child, we couldn't feel the brachial artery. Now, the brachial pulse, but I could feel a femoral pulse. Now, the child had been in arrest for a while, so we took the gamble that, okay, fine, we'll go by the femoral pulse and still continue. We brought the child back, but within 24 to 48 hours, we lost the child, unfortunately. But if you want to go by the books, it's the brachial pulse that you want to check for the kids or PDs, and carotid pulse that you want to check for the adults. If you are delivering rescue breaths, the difference between the pediatric rescue breaths is that you are delivering the single breath over 2 to 3 seconds. And remember, the adult, you are delivering single breath for 6 seconds. So you are targeting a 20 to 30 breaths or respiratory cycles For the pediatric, whilst you are targeting just a 10 respiratory cycle or breath delivery for the adult. Now, if you are able to get the patient back, as in get a pulse and get breathing, you want to monitor just like you would have monitored here for advanced life support too. If you are unable, you want to continue to the next step. Now, for kids, we assume that if their heart rate is below 60 beats per minute, they are in peri-arrest or arrest. So if you have a kid who, after 2 minutes of delivering a rescue breath, their heart rate hasn't gone above 60, you want to actually initiate CPR. You want to go down the line as if there is no pulse or there is no breathing. The rest of the algorithm relatively is the same, except in the context where you have two rescuers. So if you are alone performing CPR for a kid, you want to, a pediatric, you want to stay with the 30:2 cycle. But if you have multiple hands, or if you are two, you want to switch to 15:2. Reason being that the pediatrics arrest mostly has a respiratory cause either than a cardiac cause. So the more breaths you can get in, the higher the chances of them getting back. Now,
Hello, I think if
hello.
if the host is okay, you are back.
Yeah. I'm just struggling to share my screen again. Yeah, but I'm going to be talking through the slides once I get the opportunity to share the screen, if that's fine.
Yeah. I think we can alight him through a test so that he can make you the co-host.
Yeah, I don't know why. Okay, so I'm just going to speak about my take home for you guys. I think that was the last slide, and then I'm going to take questions and then put in the post-test um, survey until. So my first take home is ensure that um, you are both safe, you and the patient. I want you to also focus on targeting to start your chest compressions within 10 seconds of recognizing or confirming that there is a cardiac arrest. I want you to remember to push hard and to push fast. The patient is already dying. That is what I always tell myself. So the question that I ask is, do you want me to break your ribs? Although it's not a professional question, but I jokingly say, do you want me to break your ribs and bring you back to life? Because we can treat rib fractures. But if you go to the morgue, because we were very cautious about pushing your heart, we're not going to get you back. You allow for complete chest recoil. You minimize interruptions as much as possible. Let me check if he's made me a co-host now. No. And then you want to stay calm as much as possible and very confident. Believe in the knowledge and the skill that you have acquired, because once you panic, you might affect the other team members. You want to ventilate effectively, giving the breaths, watching for chest rise, one breath over a second, and then you want to make sure you are not hyperventilating. Then you want to keep at the back of your mind that cardiac arrest can happen anywhere and at any time. Now, one critical thing that you can take is that hands-only CPR is very, very much effective. So if at any point in time you think that you are not confident in delivering breaths, please just keep on with chest compressions for as long as you can. If you are two and the both of you feel that you cannot deliver breaths still, or you are not comfortable doing that, you can alternate just giving chest compressions until you get someone that has a skill to deliver the breath or is comfortable to deliver the breath. And my last take home point is that please do not be a hero. Don't try to do it all alone. It is not possible for you to save life all by yourself. And on this note, I would like to let you know that I've come to the end of my presentation. Most of the materials that were used, as I said at the beginning, is from the American Heart Association. Now, there is overlap with other trainings. Also, I want to share my sincere gratitude with Code Red Emergency Medical Services, the training center for which I trained for all my BLS, ACLS provider, and then instructor course. I'm going to drop the link for the post test into the chat. If I'm made a co-host again, I will just show you the QR code so that you can. But in the meantime, we can use a list, and I will take any questions that anyone has for me or any contributions. I will also start reviewing the chats that were put there. Thank you very much. So if there are any questions that you want, this is the post survey link for the presentation, but I'll put it up once we are done with the questions and the contributions. And my sincere apologies for the interruptions. It's rather unfortunate that today I am having challenges with my network somehow. Any questions, contributions, clarifications from the audience? Okay, it looks like I can share now, so I'm going to share the QR code. I'm going to go into slideshow. Yeah, so that's a post-test QR code. You can just use your phones to get it, and then we will see. And please feel free to just speak out a question if you have a question that you want to ask or clarification that you want to make, or a contribution, please. No single person is an epitome of knowledge. So you've read something I haven't yet come across, you want to share with us, I can also learn from you. Okay, if there are no questions.
Hello, Daniel.
Yeah.
Yeah. This is Francis.
Oh, a senior colleague.
Yeah. Well done, brother, and congratulations on your presentation and how far you've been to. The family really appreciate.
Thank you.
Someone asked a question. I would like to quickly. I think it's Nanapia, right? Yeah, Nanapia was asking, when are we to stop BLS or ACLS? Since it's a BLS training, I would like to talk about the BLS. You only stop BLS on some few conditions. I think Daniel talked about it briefly in the presentation, but I would like to just re-echo what he said. The first one is you stop BLS when the patient or whoever is in that situation responds. So when there is return of spontaneous cardiac activity, or when they start breathing, you stop the compression. And also when the professionals or when the experts do arrive, you also stop, hand over to them for them to continue. And also when you, the provider, you feel tired or you are exhausted, you have to stop, because other than that, you can also follow whoever you are trying to help, and then there might not be anyone to help both of you. So when you feel tired or exhausted, you have to stop and then seek for other means to help that individual. So basically, those are the few things you can. But first and foremost, when the person resumes spontaneous cardiovascular activity, and then you have to stop and then reassess. And then Daniel made it even much better, saying every 2 minutes you have to reassess. So even if you can't see it or can't know when you are doing the activities, I think that 2 minutes, when the 2 minutes is up, you reassess. Possibly if there is any pulse or any sign of breathing, you would know during that activity. So thank you, Daniel, for your presentation. I joined late anyway. I'm at work, but I just decided not to miss my brother's presentation. So thank you very much for the recap and then the revision.
Yeah, I'm just going to quickly put up the post-test survey. I've just put the post-test survey up. I'm just going to show the QR code one more time, and I'll allow Mystica Sylvia, if I'm right, to ask a question or make the contribution. So this is the QR code. If you want to scan it for one last time for the post-test. It's just for feedback purposes. We want to see how these trainings are helping out. And whilst they are doing that, I think Sylvia, you are free to make your contribution or ask your question. But before that, if you find yourself in conflict areas, for example, once the scene becomes unsafe, please run away. So if you are performing CPR and in a mass casualty incident, if you decide to perform CPR, although that is not recommended, and then you realize that there are still cars that are dropping down or things that are happening, please, that is also one condition. Once the scene becomes unsafe, you want to leave the patient and go. We don't want two casualties, basically. Sylvia, please, you can go ahead.
Thank you so much, Mr. Daniel. Hello, everyone. Can you hear me?
Yes, loud and clear.
This is Sylvia Mystica from Uganda. Greetings from Uganda.
Lovely.
And Daniel, thanks for the presentation. Thanks for the clarification about the BLS. I would like to have clarification about doing CPR in a neonate and CPR in a pediatric.
Yeah.
How are the intervals? And do we continue counting after 2 minutes, or there is a specific time? Because in adults, we do 32, then after 2 minutes, we repeat, we reassess.
Yeah.
Thank you so much.
Okay, so I'm going to quickly go back to so this is the algorithm for pediatric and neonatal resuscitation. Now, once you are dealing with this category of patients, if you are alone, it's 30:2. Every 2 minutes, you reassess your patient. So if you're alone, it's 30:2. Now, depending on the age, so we have some PDs that are well grown. Let's say if you are dealing with a 12-year-old, in clinical area, they are still categorized as PDs. But nowadays, when you look at a 12-year-old, sometimes they've got a very well-developed thorax. For those elderly pedics, we usually say you go with the one-hand technique. If you are dealing with neonates, we go with the two-thumb encircling technique. Now, because this wasn't predominantly focused and like our time was limited, I didn't want to go so much into that one. But the two-thumb encircling technique gives you the opportunity to go around the thorax of the neonate. Now, you want to do 30:2. Once you are 2 people or more, you want to switch to 15:2. So the difference is the technique of the chest compression, depending on the age of the child. That is one. The ratio of chest compressions to respiration or breathing or ventilation, if you are 1 or 2. Once you have an extra hand, we ask you for PDs, regardless of their size, to switch into the 15:2 because most of their cardiac arrest is respiratory related and a good percentage is shock related. So you basically want to maximize the number of ventilations that you are giving them. If it is just the rescue breaths, you realize there is a difference there also. That is, instead of giving one rescue breath for an unresponsive adult who has a pulse over 6 seconds, like every 6 seconds, for the pediatrics or the neonates, you want to do one breath every 2 to 3 seconds because you are targeting 20 to 30 cycles for them in a minute, whilst for the adult, 10-12 cycles is usually okay for us when we are breathing normally. I don't know if I've tackled the question and I've given you the differences. To be very honest with you, a proper BLS training will take a full day of both theory and practicals. I am hoping that this presentation will give you a little bit of an edge to want to take up the main BLS course because it is very critical. I want to probably meet you on the street in Uganda one day when I visit for a presentation, and then when I drop, I'm happy that Sylvia is walking by because she's going to bring me back to life. And that is the concept that I have always carried around. We need these things not just for the clinical area, but for also our family members and our friends. Sylvia, I don't know if I've touched your question.
Yes, you've done it. Thank you so much.
Yeah.
So how about for pediatric, where you saw they say 3? Is it 3 to 1?
3 to 1.
Yes. With up to which level? Is it neonatal?
So now let me clarify this. We have the protocol that we call helping babies breathe. That is a different
So I know
protocol.
that.
Yes. So I think that is a protocol for kids with severe birth asphyxia. If I am right, I stand corrected. PDS is not actually my area. But if it comes to cardiac arrest related, we usually go by this standard, whether it is the American Heart Association or the UK Resuscitative Council. It's a 30-2, and then 15:2 if you have more rescuers for the PIDs and the units. But I know there is another protocol which I also learned from one of my colleagues when I was back in Ghana, where they do the 1, 2, 3 brief, 1, 2, 3 brief, 1, 2, 3 brief. I don't know if that rings a bell, but that is a total protocol, and I would say I don't have expertise to speak into that. I can speak into this from the American Heart Association and partly from the UK Resuscitative Council.
Okay, thank you, Mr. Daniel.
Yeah, any other contributions? I think that we or questions, and then we can probably look at finishing our session. Okay. I'd like to thank you all very much for the time you took off your schedule to join. This was a refresher course for myself. It's been a while. I've been actively engaged in BLS, ACLS training, but this actually has been refreshing, and seeing you all come on board. Knowledge, you can spread the good news. You can find a very good training center. Francis, I've seen your hand is up.
Yeah, quick one about what Sylvia asked about. It's Sylvia. It's about day born, or let's say babies that were born, and then as Daniel rightly said, it's basically for asphyxia. And since babies' cardiac arrest is respiratory related, they try to do this 3:1 so that you can push more of the oxygen into circulation after pushing it in. And you also don't want to concentrate on only the breathing, because babies, when they are born, most of them don't really breathe. You have to stimulate them. So I think it's the reason why they do the 3:1, so you can have more of the oxygen in with that short interval. And then as soon as the oxygen goes in, the 3 cycles of compressions would also help circulate the oxygen that have been pushed in. So it's a different protocol, not really for cardiac resuscitation, yeah, but it's for the birth asphyxia. But in any way, when you have a newborn, you can still use it. Yeah. You can still use it, and then you'll be fine.
And I'm going to assist.
All right.
I got just mashed potato.
Okay, I will not take much of your time. We are already running 20 after 1. Once again, I'd like to thank you on my own behalf, on behalf of AFEM, as we continue to discuss among ourselves and increase our knowledge and expertise in fields that are critical to us. If you need any further directions or like training support, you can all the social media channels. If you look up for my name, Nang-Tege Daniel Ekuman, or Daniel Nang-Tege Ekuman, or Ekuman, you would find me and you can get in touch. I'm more active on LinkedIn because of the professional base. You can get me on LinkedIn, you can get me on Facebook, you can get me on Twitter at Nang-Tege. I don't do much of Instagram, but I'm there. So you can find me. We can have a chat. We can look at training packages and support for whichever area that you find yourself, and I can help signpost you to also some training faculties or centers that can help give you the skill on top of the knowledge that you've gotten today. Please try to complete the post survey for us. It's just for feedback purposes. Thank you very much and have a lovely week.
Bye.
Bye.